Okay. So today, as discussed yesterday, we said we'll be talking about acute kidney injury, which is also known as acute renal failure. That was the previous name, but now we tend to refer to the condition as acute kidney injury, or AKI. So when you're out and you hear acute kidney injury or AKI, it's basically the same as acute renal failure. Okay, so we'll be talking about that. We hope that by the end of the lecture, you should be able to diagnose a case of acute kidney injury when it comes to you, especially when you're at the ER and then it comes in. You should be able to make that diagnosis. You should be able to start treatment or institute management promptly. You should be able to know the complications that it comes with. And of course, you need to know your investigations to help you manage your patient. Okay, as we always do, we'll also touch on the pathophysiology bit of acute kidney injury. So we'll just zoom in. Once we are talking about acute kidney injury or acute renal failure, as the name suggests, it tells you that there's actually something going on acutely with the kidney. Okay, it points you to a certain direction, as the name suggests. Okay, let's say acute kidney injury. It means that the kidney has sustained some form of injury, and this injury is sort of abrupt. It's not something that has been going on for some time. It's acute, it's abrupt, and the effect of this kidney injury is leading to a rapid decline of the function of the kidney. So this definition is very, very key, or this explanation is key, because it differentiates acute kidney injury or acute renal failure from chronic kidney disease, which we'll be discussing in a subsequent lecture. The main difference here is that once you are talking about an AKI, or acute kidney injury or acute renal failure, it tends to be abrupt, and then there's a rapid decline of the renal function. And you know, the main function of the kidney or the renal system is to excrete waste substances, to get rid of urea and creatinine out of the body. So usually once you have an AKI, there's this abrupt failure in the function of the kidney. So you're unable to excrete the waste substances, and the kind of effects that you have, or the kind of injury that the kidney will go through, will lead to a rapid decline in the function of the kidney. So you realize that the waste substances will build up faster as compared to when you're looking at a chronic kidney disease, which is a more slow process and a progressive process. It's slow, but then progressively the kidney function, drops. Another main distinguishing feature between acute kidney injury and our chronic kidney disease is that most of the time, about 93% of the time, your acute kidney injuries or your acute renal failure is reversible, okay? Whereas once you make a diagnosis of chronic kidney disease, it's not reversible. It's a progressive condition which would gradually lead to the kidney failing, and then it will lead to you having to intervene by replacing the kidneys eventually when you are looking at a chronic kidney disease. But then, as I said before, with an acute kidney injury, most of the time, the condition resolves, and then the person would retain their renal function again, either to full normal or probably slightly diminished, but then most of the time it is reversible. Okay. So you can have an acute kidney injury and then you'd have a reversing over some few hours to days or sometimes even to weeks. Okay. And what we are saying is that an acute kidney injury, once this happens and the renal function becomes depressed, you could see a diminished urine output or a decreased amount of urine production. And once you are making little urine, then it means that the waste substances are not coming out of your blood. They are basically staying in the blood. So this diminished urine output, or what we call oliguria, will lead to an increase in urea and creatinine in the blood. And of course, once these substances go up in the blood, we can actually take a blood sample and look out for the substances. And this would prompt us and tell us that, okay, there's something wrong with the kidneys. And of course, once the substances are also in the blood, then you are going to have issues because you don't need these waste substances in the blood. So once you have them, they are going to affect other organs, and then it will lead to production of some additional clinical features, which we will be talking about shortly. So when you say a patient has an acute kidney injury, basically the patient can be oliguric or non-oliguric. What does this mean? As I said, oliguria means that there's a diminished or reduced urine output. Okay. There's also another term called anuria, where you are basically not making urine at all. You are making very, very, very little urine in 24 hours. Okay, so anuria is a severe form of oliguria. With oliguria, you are making some urine, but then that is below the limits that we're expecting you to make. So usually patients who have an acute kidney injury may be oliguric. It's not a common thing that you say that all of them should be oliguric. Some of them may be oliguric, whilst others may be non-oliguric. And of course, if someone has an acute kidney injury, but then the urine output hasn't been severely diminished, clearly, this person is going to have a better prognosis than the other whose urine output has been depressed. Okay, so people who are non-oliguric usually fare better than those who are oliguric. And then we can see that about 50 to 60% of all cases of acute kidney injury are basically non-oliguric. Okay, it tells you that most of the time, as I said, recovery tends to be better if you catch it early and you institute early management, or should I say early and proper management. Okay. So if you are making less than 400 mils of urine in a day, we say you are oliguric. If you are making less than 100 mils of urine in a day, then we say you are anuric, which of course is a very, very severe form of the condition. And that means that your prognosis is relatively worse than someone who is making more urine, even though both of you have been diagnosed of having an acute kidney injury. So there's a classification system that helps us know the stage of our acute kidney injuries once our patients come in. And then it's staged from 1 to 5. And of course, once you get to stage 5, then it means that your condition is more severe than the person who is in stage 1. Okay. And then this criteria, as we know, it is called the RIFO criteria. And it's an abbreviation that stands for risk, injury, failure, loss, and end-stage kidney disease. So if you take the first letters of these parameters, risk, injury, failure, loss, and end-stage kidney disease, you have what we call a RIFO. Okay. This RIFO criteria was basically published by a group, the Acute Dialysis Quality Initiative Group. So they published it. And we also have adopted it here, and we use it to assess our patients to know their stage or the severity of the AKI we are dealing with. So what does risk mean? So basically, if you have a patient coming to you and you are suspecting an acute kidney injury, you take sample for blood urea, electrolytes, and creatinine, or BE and creatinine. And your serum electrolytes, usually that's what we look at. It's very, very key in our diagnosis. Your serum electrolytes is about 1.5 higher than the upper limit of normal. Then it means that there's a problem there. Let's say if we are expecting the upper limit of normal to be about 110, and then you have a patient coming, we take BE and creatinine level is about 1.5 times higher than the 110 we are expecting, then we know that, okay, this patient will be put in the first category, which is called the risk category. Also, you can use the urine that this patient is producing per hour. So if the patient is making about 0.5 mils of urine per his weight per hour within 6 hours, if your patient is making less than that, then you can say the patient is in the risk category. When we move to injury, we are saying that if your serum creatinine level is about ×2 of the upper limit of normal, then we would say, all right, okay, you go into the injury category. So let's say if we are using 110, and then our patient comes and then the serum creatinine is about 240. 240 is, of course, more than ×2 of the 110. So you put this patient in the category of injury. Okay, of course, if urine output persistently is below 0.5 mils per weight in kg per hour in 12 hours, then we say the patient has an injury, should be put in the injury category. Okay, we can also look at the failure category, where the serum creatinine levels of the patient should be more than 3 times what we expect, the upper limit of normal. So still, let's say we're using 110 and then we are getting a serum creatinine level of about 400. Clearly, that's more than 3 times of 110. So this patient, we can say, is in the failure category. Or if the patient is making less than 0.3 mils per weight in kg per hour in 24 hours. Okay. Also, this risk injury category, we can sometimes use the glomerular filtration rate to assess. So if we are using the glomerular filtration rate and we're saying that there's about 25% decrease in the glomerular filtration rate, that will go for risk. If there's about 50% decrease in glomerular filtration rates, that will go for injury. And if there's about 75% reduction in your glomerular filtration rate, then that will go for risk injury failure. When we look at the last two, the first one being lost, then it means that persistently you have the AKI for more than 4 weeks, then we say that you'll be in the category of loss. And if your AKI persists for more than 3 months, then we're saying that you've been pushed to the category of end-stage kidney disease. Ideally, we expect that by 3 months you'd have recovered. If you go beyond that, then it means that we are putting you in the category of end-stage kidney disease. Okay, so that is what our RIFLE criteria is about. So of course, if ESKD, as I put down there, is end-stage kidney disease. Okay. So how does this happen? So that would take us to pathophysiology. Okay, and then from pathophysiology, we'll know the classifications of the types, and it makes things easier that way. So one of the pathophysiology or the processes for an AKI is when you have the glomerular filtration rate is basically decreased because the blood that is coming to the kidney itself is decreased. When you have a decreased renal perfusion, then clearly the filtration activity of the glomerulus would also be decreased. Okay, when you have more blood coming to the glomerulus, then there's an increased filtration activity, it gets rid of the urea and creatinine and all that. But then when you have a diminished perfusion to the kidney, then you are in trouble. And a classic example is if you have shock, let's say hypovolemic shock, and there's poor perfusion to the kidneys, clearly you are going to have a diminished blood flow to the kidney, and this will lead to a diminished glomerular filtration rate. And once the glomerular filtration rate is diminished, it tells you that it's unable to get rid of the excess urea and creatinine. This excess urea and creatinine, which we don't want, would stay in the blood and have negative effect on the body. So that is one of the pathophysiological processes. Also, you can have an acute damage of the structures in the kidney itself. Okay, so yesterday, you remember I showed you a diagram of the nephron where you have the Bowman capsules and then the proximal convoluted tubules, lipofriendly distal convoluted tubules. These tubules are basically lined with cells. Sometimes you can have a condition that leads to destruction of these cells lining the tubules, okay? You can have some sort of poor perfusion, which would also lead to destruction of the cells lining the tubules. And this is what we call acute tubular necrosis. And once you have this acute tubular necrosis, it means that the function of the kidney is basically going to be diminished because you need these tubules for reabsorption of, basically reabsorption of fluid and special products that you don't want the body getting rid of, to reabsorb it into the system and all that. But once you have an acute tubular necrosis, then basically the unit or the basic structure of the kidney will become compromised. You can say it becomes paralyzed, is unable to function, and hence you are going to have an elevated level of urea and creatinine, which will lead to clinical features that we don't want to see. Okay. In some cases too, you could develop a condition that puts pressure or increases the pressure in the kidney and hence the basic unit of the kidney, that is the nephron. So for instance, if you have a stone sitting in the ureter, okay, and basically this stone is preventing urine from bypassing the ureter to get into the bladder. So there's accumulation of urine above where the stone is. And this accumulation persists. And then there's now accumulation in the kidneys. It tends to increase the pressure in the kidneys. And once there's an increased pressure in the kidneys, what will happen? It's going to basically affect the whole filtration process. Because ideally, if, let's say you have a sieve and you want to sieve something, you pour whatever you are sieving under high pressure and it sieves it and it comes out. But if you are sieving something and you are pouring, but then the pressure below, or there's a negative pressure forcing whatever you are sieving upwards, then it means that the function of your sieve will basically be compromised, okay? So that's the same thing that happens. Pressure can build up in the renal tubules, and once this pressure builds up, it compromises the activity of that Bowman's capsule and the glomerulus, which is supposed to filter. Okay, ideally you need more pressure in the Bowman's capsule and the glomerulus than in the tubules. But if the pressure in the tubules overcome the pressure in the Bowman's capsule, then clearly filtration will become compromised. Okay, so that is the pathophysiology behind it. That would bring us to the categories, which we basically talked about during the pathophysiology. So one, you could have what we call a pre-renal failure. What does this mean? It means that this patient who has an acute kidney injury, the problem is actually not due to the kidneys. The problem was due to something, and this has basically led to a diminished function of the kidney. For instance, if you have a patient who has persistent diarrhea and vomiting and loses a lot of fluid, there's going to be poor perfusion to the kidneys because this patient is going to go into a state of shock. Okay, so clearly this acute kidney injury didn't arise from the kidney directly. It arose from something. The patient had gastroenteritis with severe dehydration, which led to shock, and then this shock led to poor perfusion to the kidneys and hence the acute kidney injury. So this is what we call a pre-renal failure. You understand? So sometimes the patient can have heart failure, the heart is failing to act as a pump, and hence the patient will go into cardiogenic shock. The main problem didn't arise straight from the kidney. The main problem arose from the heart, cardiogenic shock, poor perfusion to the kidneys, and hence the kidney would fail. That is what we call a pre-renal failure. Okay, so this pre-renal failure means that basically there's something that is impairing the perfusion to the kidneys and hence leading to a secondary function in the loss of what the kidney is supposed to be doing. Then you have what we call renal or intrinsic. Okay, this one, as the name suggests, tells you that the problem is coming from the inside of the kidney itself. So a lot of conditions can lead to that. You can have trauma to the kidneys, you can have some form of acute tubular necrosis secondary to some antibody-antigen reaction coming to land on the kidneys and destroying the kidneys directly. All of this will lead to an intrinsic loss of kidney function. Okay, so we call that renal. And then the last one is post-renal. So here, the problem clearly is not coming from the kidney, but it's arising beyond the kidney. So what are we saying? So after the kidney, the next thing you got there is what? Your for the renal pelvis in the kidney. So it comes out through the ureter and then it comes to the bladder and then the urethra. If you have any impairment along the post-kidney, so any impairment of the ureter, of the bladder, of the urethra, you are going to have issues. For instance, if you, as I said, if you have a stone or you are bleeding and some cast has formed bilaterally in your ureters, something we talked about yesterday, then clearly you are going to have some sort of obstruction to the urinary tract system. So urine that is being produced by the kidneys will be unable to bypass this obstruction, and hence it would go back, increase pressure in the kidneys and lead to damage of the kidneys. This damage to the kidneys is basically secondary to the obstruction, and the obstruction is beyond the kidney. So this is termed as a post-renal acute kidney injury. Okay, you could also have something like a tumor, which is obstructed the urethra, and so the patient is unable to pee, urine stores in the bladder, pressure increases, it goes all the way up to the kidneys and then damages the kidneys. You can have lymph nodes becoming enlarged, and this will obstruct the urinary tract system, and all this will lead to renal failure. So this diagram here shows what I've been trying to discuss basically. So if you look at the very first part, pre-renal causes, you can see it's saying something about contrast, sepsis, hypotension, diarrhea, vomiting. All these things will lead to a poor perfusion to the kidneys, and hence there's going to be a diminished function of the kidneys. Then you can come to the intrarenal or renal causes, where the problem is actually due to the structures of the kidney. So you can see they've drawn the nephron nicely here, and they've put some medical conditions there. So acute tubular necrosis or tubular injury, there's some destruction over there. You can see the blood vessels in the kidney itself have problems and all that. So that is renal. Then the last bit, you can see the post-renal causes, where you can see something like a lymph node obstructing the ureters over there. You can see something like blood clots there. You can see malignancy. Sometimes you can have schistosomiasis. All these things cause an obstruction, and then their patient is going to have a kidney injury. So that is what we mean by pre-renal, intrarenal, and post-renal. Okay. So if we take a look at what we've talked about, basically the causes, we can see that there are numerous causes. Okay, so basically, if we are looking at the renal parenchymal disease, what are the things that would lead to an intrarenal failure or an intrinsic renal failure? Then you can see we said acute tubular necrosis, where we go back here. Ideally, when you look at this, this is the renal tubules, and inside the tubules is lined by something of this sort. So sometimes you can have a necrosis, which would lead to destruction of these cells lining the tubules, and it sheds inside. And once it sheds inside, the function of the renal tubule becomes what's compromised. And even after it's shed inside, it also causes some sort of obstruction, and then it makes the problem even worse. Okay, so this is what I've been talking about. So you can see that clearly this is lined by nice cells here. The cells become destroyed, function is impaired, and then there's what's an obstruction. And once you have an obstruction, pressure is going to build up here. This pressure that builds up is going to go so high that it would become more than the pressure here. Okay, and we don't want that. Usually we want more pressure here in the glomerulus and Bowman's capsule than in the tubules. The higher the pressure here, the more you are able to push blood through for filtration. Okay, but because of this obstruction, now pressure builds here, it overcomes the pressure here. And once this happens, then you know that the whole filtration process becomes impaired. Okay. So there are other ones. So there's inflammation of blood vessels, which is called vasculitis. Sometimes when the BPs go so high, it directly affects the function of the kidney. There's also hemolytic uremic syndrome, which is a combination. You have basically have a combination of reduced platelets, anemia, and also reduced function of the kidneys. Cholesterol embolism. So of course, you know what an embolism is. So when cholesterol migrates in circulation and goes to plug any of the blood vessels in the kidneys, then you are going to have obstruction to blood flow, which will lead to diminished function of the kidneys. There's also thrombotic thrombocytopenic purpura, which leads to blood clots. There's preeclampsia, and then there's what we call crescentic glomerulonephritis, which another name for it is also rapidly progressing glomerulonephritis, and this is usually secondary to an antibody antigen reaction, lands on whatever the basement membrane. So similar to what we talked about yesterday. So there's an anti-glomerular basement membrane antibody which is produced. So this one will be like presents like an autoimmune condition, and usually it's very, very rapidly progressing, and it leads to an acute kidney injury and diminished renal function very, very, very fast. Okay. So the acute tubular necrosis, we are saying that it's usually due to renal ischemia. So if you are bleeding, you have burns, severe gastroenteritis, pancreatitis, you can see that all these conditions have something in common. And what they have in common is what? Shock, as you can see. Okay. Sometimes patients get an RTA, and kidneys will try getting rid of the myoglobin, which is in the muscle, and this myoglobin can be toxic to the kidneys. So all these ones do have something in common, toxicity to the kidney. So myoglobin, hemoglobin, which is exposed, aminoglycoside, lithium, platinum, all this are toxic. We say they are nephrotoxic in higher quantities. Okay. And then of course, ACE inhibitors. Remember yesterday I said that we use ACE inhibitors in kidney disease when there's proteinuria. It helps you because it has an antiproteinuric effect. However, if the patient has a renovascular disease, we don't give it. Okay, so ACE inhibitor would pop up here again. Usually when you use ACE inhibitors, this is what happens. So when you take your glomerulus, as you can see, this is the afferent vessel, which is bringing the blood into it, and this is the efferent vessel. So, of course, per science and our physiology, we know that for you to have enough blood here in the glomerulus for filtration, what should happen? Some pressure should be built up here. How do we build up this pressure? this afferent vessel should dilate enough to bring more blood in, and at the same time, this efferent should constrict. So once the afferent is dilated and the efferent is constricted, and it means more blood comes in, it doesn't go out, so pressure builds up. But then if the afferent dilates, gets blood in, and at the same time, this efferent is also dilated, then it means the blood that is coming in won't stay, it will go out. Okay, and that is the effect ACE inhibitors tend to have on the efferent vessels. So basically, ACE inhibitors will lead to dilatation of the efferent vessels. And once this happens, it's basically going to diminish your pressures that you are hoping to attain. And this is going to lead to depression of your glomerular filtration rate and hence depression of your renal function. So disease progression, basically, it can either be oliguric or non-oliguric, which we've talked about, and this is dependent on the severity of the renal insult. Clearly, if the shock is very severe, then the patient might be oliguric. Okay, so it depends on the extent. We expect that within a week to about 3 weeks, the patient should recover. Okay, the glomerular filtration rate may be a little bit low, but then with time, urine outputs, we expect that should improve, okay? And sometimes what also happens is, even though your glomerular filtration rate is low and you're expecting that your urine output should be low, because the tubules, the renal tubules, as we talked about, has been destroyed and is defective, is unable to reabsorb. So even though your GFR is low, there's also diminished reabsorption. So you still have some urine coming through, okay? Sometimes some people have it going beyond 6 weeks, okay? But most of the time, as we said, the renal function should return to normal, or at least near normal. But once you go beyond 3 months, then we know that we are going to change your classification from acute kidney injury to probably a chronic kidney disease, which was secondary to an acute kidney injury. Clinical features. So based on all that we talked about, the clinical features should make sense. So basically the clinical features is secondary to one, the increased level of urea in the blood is going to give you problems. So all the features associated with uremia, for instance, nausea, vomiting, itching, confusion, headaches, abnormal bleeding, sometimes you vomit, there's blood is coming from your nose. All this is secondary to increased urea levels. You would see them. You won't feel like eating, and it's all because of the increased urea. Clearly, if you are unable to pee, then we say you are oliguric, and because you are not peeing, you are going to retain a lot of fluid, so you become edematous, okay? That's also another clinical feature that we tend to see. And then there's electrolyte imbalance. The kidney is responsible for electrolyte balance. Once the kidney function is depressed, you are unable to excrete potassium. So potassium levels will build up in the blood. You develop what we call hyperkalemia, which can be severe, can kill you, can give you a cardiac arrest. Also, you have issues with calcium. So you tend to have hypocalcemia as well. And because you have excess fluid in the body, clearly it's going to dilute the sodium in the body. So you have something sort of a dilutional hyponatremia, okay? The more salt you take to, the more the fluid accumulates and makes your edema worse. Because the kidney has failed, ideally the kidney is responsible for maintaining acid-base balance. So the kidney helps in the excretion of hydrogen ions. Once the kidney function fails, hydrogen ions is unable to be excreted, it stays in the blood, and hence your pH will decrease. You have what we call metabolic acidosis. And then of course, arrhythmias, and this is secondary to the electrolyte imbalance. As I said, hyperkalemia can affect the heart. The urea level can basically affect the pericardium. You can develop what we call a uremic pericarditis, okay, and that can compromise the heart to lead to heart failure. Excess fluid in the body would eventually lead to pulmonary edema, patients who have difficulty in breathing and all that. The urea levels go up, you can have seizures, you can go into coma. We also said increased urea levels can make you bleed, so you vomit and there's blood in there. How do we investigate our patients? So basic investigations, of course, BE and creatinine is key because all we've been talking about, we're saying that urea and creatinine levels will accumulate in the blood. So you need your BE and creatinine, it's very essential. And then urinary, it's not so bad. You can get some information from there. Sometimes if there's a very bad infection. Remember we said that yesterday, we said very bad UTIs can actually lead to renal failure. So if you have a very bad infection, urinary will help you. Your full blood count will tell you about your HB, especially if your patient probably has some uremia and is coughing or vomiting blood or has epistaxis. HB is very key. We've also talked about conditions like hemolytic uremic syndrome where HB drops, platelets also drops. All this can be found with the full blood counts. It's very key. Your WBCs will go up if there's a very, very bad infection in sepsis. Full blood count is very key. So you see the full blood count does a lot of things for you when you want to diagnose. It's not just about HB. If you say HB, tell us why you're saying HB. Or HB because there's hemolytic uremic syndrome, which could be a cause, and that can lead to low HB. Or platelets because hemolytic uremic syndrome can cause low platelets. Thrombotic thrombocytopenic purpura can cause low platelets. This could all be a cause. WBC because the patient could have a very, very bad sepsis, white blood cell can go up. So once you say this, examiner is happy, everybody is happy. You can also think through the cases once you know what your full blood count should do. LFT, very, very, very key. Because once you are going into shock, systemic failure, liver function tests, liver function, liver enzymes and all that can also become compromised, okay? We sometimes would have to do an abdominal ultrasound scan. In fact, most of the time we need to do it so that we take a look at the kidneys and see exactly what is happening. If your kidney function is depressed, we are thinking of two things. Either you have an acute kidney injury or maybe you have a chronic kidney disease. Maybe you have some BP or diabetes and you have a chronic kidney disease. Your ultrasound scan helps us. If your condition is chronic, we will see features that point to chronic kidney disease. If it's acute, usually you realize that the kidney is looking okay. It's not showing very distinct features. Okay, if it's chronic, as we'll be talking about in subsequent lectures, you are going to see what we call a loss of corticomedullary differentiation. Big word, but simple meaning. The kidney is made up of the renal medulla and the renal cortex. Ideally, there's a very nice differentiation when you do the scan. You should be able to see the medulla and the cortex separately. If you have a chronic kidney disease, there's a loss of this demarcation. So you can't really differentiate between your renal cortex and your renal medulla. And that is a sign of chronic kidney disease. You don't see that in acute kidney injury. Okay. If your acute kidney injury is also due to post-renal causes like obstruction and all that, imaging study will be very vital because it will pick up these obstructions and you'll be good. Auto antibodies, as we've talked about, anti-glomerular basement membrane, anti-neutrophil cytoplasmic directed to the kidneys and lead to distraction and an acute kidney injury. Okay, we talked about renovascular disease. So there's supposed to be aortorenal angiography where you put it in and then you can actually see if you have any obstruction there. Okay, then of course a renal biopsy is also essential. It helps you know what you are dealing with. So we are saying most of the time patients recover. So our main aim and our job as clinicians is to try and keep the patient alive until they recover spontaneously. You can't cure the patient there and then, but you need to offer supportive treatment. It's a gradual process and make sure that you don't stop your supportive treatment until the patient recover and kidney functions come back. Okay, so what do? We are saying that we want to restrict sodium, we want to restrict potassium. We're saying high levels of potassium will lead to arrhythmias. And we're saying hyperkalemia is a feature of AKI. So make sure you're restricting potassium. Your sodium, you're restricting it because once the patient takes more sodium, water is going to follow and it's going to make it worse. Even though we said the patient has hyponatremia, you don't have to administer sodium because this hyponatremia doesn't mean that your patient lacks sodium. However, it means that you have excess fluid there, the edema is in excess, and this excess edema is causing what we call a dilutional hyponatremia. It doesn't mean that the patient needs sodium, okay? The other thing is fluid and electrolyte imbalance. So you need to make sure that you are balancing your fluid. When you are giving fluid, you are listening to the chest because you don't want to overfill the patient's lungs and then cause serious effect as well. So you are very, very cautious when you are dealing with that. And then, of course, you need to look at your electrolytes and make sure they are in balance. In terms of edema, you are giving your Lasix or your furosemide to your patient. Once it comes, Lasix or furosemide has a very, very wide safety profile. So depending on how severe it is, you can even give as high as 120 to 240, okay? And then you taper down, you can be doing 80 milligrams of Lasix every 8 hourly. You can come to 40 milligrams every 8 hourly and all that, okay? And then we know that a medication like dopamine also helps. It has an effect on dilatation of renal vasculature, so it improves your blood flow to the kidney. So if you need to give, you discuss with your specialist or your nephrologist and they would give it. Okay. So how do we manage the hyperkalemia? It's very, very important that you do your BE and creatinine. And once you are doing it, you are not only looking at your urea and creatinine, you are also thinking of potassium because that would even kill your patient faster than the urea and creatinine levels that are going up. Okay, so once there's hyperkalemia, you need to manage. How do we manage this? First of all, you need to protect the myocardium because you're saying high potassium levels will cause arrhythmia. So we protect the myocardium by giving 10 mils of 10% calcium gluconate IV. We give it slowly over 5 minutes, and this will protect the myocardium. Then next, we aim at reducing the potassium levels in the blood. Insulin is capable of reducing potassium levels in the blood. It pushes potassium levels from the blood into cells. So you are giving 10 units of IV insulin. Okay, you are giving soluble insulin, 10 units. But of course, we know that insulin also causes what? Hypoglycemia. So once you are deciding to give your insulin, it's good to give the patient some dextrose so that the patient doesn't go into hypoglycemia. So you give the patient 50 mils or 50% dextrose, okay? In addition to your 10 units of your IV soluble insulin. You treat infections, your WBC would point you. Once it's high, you do a culture, a blood culture or a urine culture that points you to the kind of infection you are dealing with, and then you treat. The antibiotics that will be given to you by the culture, make sure you've read on the antibiotics and you know that it doesn't have any toxic effect on the kidneys. Antibiotics like gentamicin, amikacin, all these aminoglycosides are nephrotoxic. So we usually would want to avoid them. If you are not comfortable with any antibiotic that your culture and sensitivity is giving you, always read and be sure that it won't have any effect on the kidneys. We do that every time. You refer for side effects and then be sure that, okay, this antibiotic is safe for my patient before you go ahead and you give, okay? So let's move to the last bit. So after all the supportive treatment, sometimes it's very essential that you do what we call a hemodialysis or hemofiltration for your patient, okay? Main difference is that usually your hemodialysis removes very, very, very small particles that it decreases the increased level of your urea and creatinine. Hemodialysis is targeted to the smaller molecules. Hemofiltration can take out larger molecules as well and not just the smaller particles. Okay, so when would you want to do this? This hemodialysis or hemofiltration is also called a renal replacement therapy. So if the patient has a very, very bad uremia or urea levels is so high, you would want to do either hemodialysis or hemofiltration for the patient. So how would you know the uremia is bad? Of course, if the patient is vomiting blood, confusion, coma, it tells you urea level is above the roof. You'd see that too per your BE and quinine results. You would want to do a renal replacement therapy. The biochemical derangement are severe, like a very, very bad hyperkalemia and whatnot. You would want to do that. If there's severe acidosis, H+ is so high, you want to sort the patient out. If there's pulmonary edema, that's also another indication for your hemodialysis or filtration. If maybe the patient has been exposed to lithium or any of these nephrotoxic agents and you think that is what is causing the problem, then a renal replacement therapy or hemodialysis hemofiltration would come in very handy. Okay, so I think we are right on time. I'll take questions and then we can close and rest for today, and hopefully we will discuss our next lecture session. So floor is open for questions, please.
Hello, sir.
Yes, please.
Sir, if you look at the hyperkalemia and then giving of the furosemide, I was thinking also that maybe when you initiate the furosemide, you are going to lose some amount of potassium in the blood. Then looking at that and the time of initiating the treatment with the won't you rather let the person, maybe after giving it, if you are not careful, won't the person go into hypokalemia rather after you initiate the furosemide and you do all this infusion of the insulin and all that? So it's like most of the potassium in the blood will now move into the tissues or the cells, and then with some loss with the furosemide you are giving.
Yeah. So that's a good question, but it's basically a very tight balance. It's basically a very tight balance. And usually when you do your BE and quinine, they'll give you a potassium levels of maybe about 3.5 to maybe 5 or 5.5 as your normal range, sort of. Okay. If you have a patient like that and you know you are going to give Lasix and you are expecting to challenge the kidneys for the patient to excrete, and maybe potassium levels is probably around 4.5 or 5. You are not so worried that at that point you want to institute your insulin, calcium gluconate, and then your dextrose protocol. But if clearly your first BE and quinine comes and then your potassium level is around 6.5, you can't say that, let me give the Lasix and then after I give the Lasix, I'll go and do a BE and quinine again and come back before I give. Okay, because you don't have the time. You give the Lasix and they'll take sample, and this is Ghana, it might take a little bit longer. It comes back and then still potassium level is around 6. Then it means you should have even given in the first place. And by the time you realize patient will be dead, you feel so guilty for saying, oh, I'm giving Lasix, because that Lasix is not the management protocol for hyperkalemia. Once you diagnose hyperkalemia, you need to manage, and rather your focus should be about trying to balance and not over giving your Lasix. So trying to balance, and remember what we said about input and output chart tightly. So whatever you are giving in should correlate to what is coming out. So it's just a very tight balance. And this patient is, we will classify them as patients who are in that severe extremis and they can just tip over and die. So your monitoring should be spec on. You should be monitoring this patient well so that you are not overgiving something or undergiving something. Okay. So once you make a diagnosis of hyperkalemia, don't say your Lasix will sort it out. It might bring it down a bit, but if the patient dies and goes to court, they would sue you for negligence of duty or under management of your patients, because they'll come and refer to your book and they'll see potassium level 6.5 and they'll see that the only thing you gave was Lasix. And histopathology will come and say the patient died from cardiac arrest. that is it for you. They'll sue you or your facility. You get it? So
Okay,
once
sir.
you make the diagnosis, you manage. Okay.
Okay.
Sir,
Thank you,
please,
sir.
I have a question.
You're welcome. Yes, please.
Sir, please, I want to know, as a physician assistant, at what point must I refer to the specialist in dealing with renal patient?
Okay. So as soon as you see a patient with renal condition and you institute your basic management, you try and get into contact with a nephrologist. You understand? So once you pick up acute kidney injury, you pick up nephrotic syndrome, you are thinking about the specialist straight up. You don't have to waste time. And that's why I said that this management over here, sometimes you might not even be the one instituting the management for the hyperkalemia because you might have referred your patient. But what if you are the one on duty and the patient comes and then you do BE and crying because you know this thing, you do BE and crying and diagnose AKI. And then you realize urea is very high, potassium is very, very, very high. And you still want to go ahead and refer your patient. You've called major referral sites, they are telling you there's no bed. What would you do? And that's why you need to know these things. But as soon as you make the diagnosis, you are on your way to instituting basic management and communicating with your specialist for possible referral.
Okay, thank you very much.
You're welcome.
I also have a question, but it's not related to.
That's fine.
It's related to COVID topic.
Okay.
So I was at one clinic and then a patient came in.
Yeah.
She was a lady. She came in with body pain and other stuff, right? So after running labs, they realized that the white blood cells are at the yeah. So the doctor pointed to let me say a urine tract infection.
Okay.
So at that particular instant, I realized that the symptoms the lady was complaining was related to COVID.
Okay.
But the lab too realized the lab result that came out made us know that there was no parasite. Everybody was pointing to maybe malaria or then COVID test was
maybe a UTI. Yeah.
Yeah. So I told them that no, let's start initiating something with COVID. But they were like, no, it is UTI. So probably my diagnosis was right. They discharged her, giving her antibiotics, but then she was rather admitted at a different clinic, and that place too, they did not find COVID. They gave her anti-malaria drugs, infusions, everything, before realizing it was COVID. So my question is that way as well, because it was quite strange.
Okay. So as we know, let me just add this. So something with acute kidney injury, even one of the other causes, which of course we've now seen is COVID. So it's good you brought COVID up. So don't forget that once you make a diagnosis of COVID, you are looking out, and that's why usually when we diagnose COVID, between every 2 to 3 days, we are doing repeat chemistries to look at the BE and quinine, because sometimes the patients end up developing an acute kidney injury. So we are doing those labs to be sure. So yes, COVID is also one of the causes for acute kidney injury. And as for the diagnosis of COVID, it keeps, every single time, something new keeps coming up. For me, I would always tell you that diagnosis of COVID, it doesn't have any specifics. Diagnosis of COVID is based on a high index of suspicion. That is what I've told myself. So it's just like your pulmonary embolism and what's not. Diagnosis of those things are based on high index of suspicion. So as a clinician, your mind should be always sharp. And even in the midst of this pandemic, if you see anything that is not making sense, febrile illness that doesn't add up to any of the labs present, just start thinking of COVID. It won't kill to ask the patient to do a COVID test. You won't have classic signs of COVID. Yeah, so you'll point to you and say, all right, okay, yeah, so this is likely to be COVID, let's test. But sometimes you just have general body pains, headaches, especially in the young people, maybe some general body pains, headache and whatnot. And if you don't have that high index of suspicion, this patient may either recover without even knowing they had COVID. And I'm sure most of us had something like that along the line. Trust me, most of it was COVID, but we recovered even without knowing it was COVID. Okay, but then you might also be unlucky and then you end up in the ER with acute respiratory distress syndrome. And you might not be, so lucky to get out of there. So high index of suspicion, as clinicians, as we are in the consulting rooms or at the ER, once you have any patient comes to you with a febrile illness and labs are not adding up, do a COVID test. It's something that we do on our ward. Even now, routinely, we do COVID tests for patients going to theater. We will do a COVID test for you. We want to be sure. If you're on the ward and we realize that we've done some CS or something and you have some temperature, we know sometimes they have temperature post-op pyrexia or something, but now we entertain COVID when you have a post-op pyrexia. So you should have that kind of index of suspicion, especially when a patient comes with an AKI to you. One of the tests you need to do is to do a COVID test. Okay, so thanks for bringing that one up. We can take one last question and then we will sum up if there's any. Okay, looks like there are no questions. Or you can't hear me. Let me know if you can hear me, please.
No, we can hear you, sir.
We can hear you.
We can hear you.
And clear.
Do you have any other questions? Next week.
So we can't hear you now.
Okay. I'm saying that so we'll break for this evening. Let's take a break for this evening. And then what we'll do is hopefully the next time we meet, maybe on Friday or maybe on Saturday, we'll have a brief question and answer session. What we've learned so far, then we move on to talk about chronic kidney disease. That will be the conclusion of our renal lectures, and then next week we'll touch on a different system. So enjoy your evening. Good evening.
Okay, good night.
Thank you.